which we are going to discuss today, and which is why we are here, is hypoglycemia in non-diabetic patients, right? That's the topic, and we'll be covering, looking at key cases, some interesting cases, and also looking at some very interesting, learning points also from this. Slide changer. Okay, it's okay. Okay, so let's look at the first case, and these are all. There are three cases. All of them are real life cases. All three. We have and pretty recent also, so you will be able to kind of, I'll also have some fresh memories of these patients. So this is a 40-year-old male patient presented with generalized weakness, excessive sweating, and palpitations, generally in the afternoon, before lunch and after lunch, right? So through lunch pehla chha na, you would have a little bit of, and his mother is a patient of mine having diabetes. So he once, he checked his blood sugar once when he was having these symptoms, and that time the blood sugar was 62 when the symptoms were there, right? And mainly the symptoms were post-meal, mainly. And he sometimes takes, short-acting carbohydrates during these episodes, and the symptoms are relieved. So he says, okay, I do develop the symptoms. And I also remember a few years back, I had a friend who was a physician who had a very similar clinical presentation. Okay, I am sitting in the OPD, and it's busy OPD, and after a few hours, just before lunchtime, maybe 1 o'clock, 1:30, OPD is very busy, and I start developing hypoglycemic symptoms. And then, I check it, and the sugar is 50s, 56, 60. And then, unfortunately, I have a lunch, and after, again, late in the afternoon, 4 o'clock, 5 o'clock, again, I have symptoms, right? So these type of presentation is not unusual in a lot of patients. So broadly speaking, I'm sorry, the slide is not very visible, but broadly speaking, when we deal with a patient with hypoglycemia, right, a very important thing we have to understand is that first we need to differentiate whether we are dealing with a diabetic patient having hypoglycemia or non-diabetic patient having hypoglycemia. Diabetic patient having hypoglycemia is very straightforward, right? So often it could be because of the sulfonylurea which they are taking, or some other medication. They skipped a meal, maybe they are taking insulin. So these are the general issues. But when you are dealing with a non-diabetic patient having hypoglycemia, we need to first establish whether you are truly dealing with a disease or you're dealing with a patient who is sometimes anxious, right? Because remember, hypoglycemia symptoms are, a lot of them are adrenergic symptoms, noradrenaline symptoms, right? Sweating, palpitations, tiredness, weakness. These are also symptoms of sympathetic and parasympathetic systems, right? So it's very important that we differentiate whether we are truly dealing with hypoglycemia or we are dealing with a patient who is a little bit anxious. And that's why many years back, Whipple actually came with a strategy, right, which is now called the Whipple's Triad. Unfortunately, whatever reason, he obviously didn't have glucometer at that time, but if you had, so he, in his own wisdom, said that to establish that the patient truly has hypoglycemia in a non-diabetic person, you need to have three things which you have to fulfill. One is the blood glucose should be in hypoglycemic range, right, less than 70. Okay. Second is the symptoms of hypoglycemia are present when the glucose is low, right? So when the patient has low glucose, the symptoms are present. That is the second thing. And when symptoms should be relieved after the carbohydrate or maybe glucose or something is taken, and the hypoglycemia is corrected, the symptoms should be relieved, right? So if these three criteria are fulfilled, only if these three criteria are fulfilled, then you can truly say the patient has non-diabetic hypoglycemia, which you need to investigate further. You will feel that this is so simple, this is so straightforward. Anybody could say this, but when you see the wisdom in this, there is a lot of intricacies, right? Sometimes, the patient has anxiety-related symptoms, but the glucose is 100. Will you call it hypoglycemia? No, right? Sometimes the patient has blood glucose in the glucometer of 69, but it doesn't have any symptoms, right? Would you investigate further? It could be a lab error, it could be a glucometer error, maybe, right? So all the three criteria need to be fulfilled if you want to really consider investigating the patient further, and this is something which is very, very essential. So whenever you have a patient where dealing with a non-diabetic hypoglycemia, right, these three criteria should be fulfilled, right? Now sometimes obviously in ICU patients there are different issues, but generally, in general, when you have an outpatient, you need to fulfill this. Now, second very important thing when you have, so the first question is diabetic, non-diabetic. Second question is it truly hypoglycemia or not? Third question is the hypoglycemia predominantly, and this is very, very important, predominantly, is this a fasting hypoglycemia or is it a postprandial hypoglycemia? So if you see our case in our patient, the patient mainly complained of hypoglycemia in late before lunch, right? When he's little bit fasting, but he still had a breakfast, and late in the afternoon, 4 o'clock, again after lunch, right? So patient mainly has postprandial hypoglycemia, right? There are different set of conditions which lead to postprandial hypoglycemia. There are different set of conditions which lead to fasting hypoglycemia. I'm sure you would have all encountered patients in your practice who comes with seizures, right? Morning sugars are 30, 40, right? Late night they come to the emergency, right? With low sugars, non-diabetic, right? These are fasting hypoglycemias. These are a different set of problems. And these postprandial hypoglycemias are a different set of problems. So technically, by definition, when the hypoglycemia occurs less than 5 hours after a meal, it is considered postprandial hypoglycemia. And when it occurs more than 5 hours after a meal, it is generally fasting hypoglycemia. So this is a broad differentiation we need to do. Then, what is the next step? So this is, I have made this interactive, so there will be questions in between. So you saw this patient, right? Patient had mainly postprandial hypoglycemia, right? Patient is otherwise educated, smart, person, and Whipple's Triad is fulfilled. Because when he checked the sugar, it was 62. He had symptoms of hypoglycemia, and when he corrected the sugar, his symptoms went away, right? So patient has hypoglycemia for sure. Patient is not diabetic, and it's mainly postprandial. So what is the next step you will do in this patient? Would you do you'll call the patient in the morning, or you send him to the lab and say that fasting insulin and C-peptide, would you do that? Would you do a mixed meal diagnostic test or extended OGTT, or would you directly send the patient for a CT scan to look for insulinoma? Any suggestions? OGTT, right? Correct, right? So that's the correct answer. So remember, whenever you have, and this is a very, very important point, I'll come to this point again and again, and this is very important for all of us to understand. Whenever you are dealing with a patient with hypoglycemia, the very important step in evaluation is to capture a blood sample during hypoglycemia. And this is what is known as a critical sample, right? Whether you are dealing with a pediatric or a neonate with hypoglycemia, or you are dealing with an adult with hypoglycemia, this is a very critical step, that a sample should be collected. Now, if you have, doctors in your emergency room, or if you have medical officers in your hospital, right? Sometimes, during emergency, when that first time patient comes with hypoglycemia, you are not present. So anybody in your staff should be aware of this, that hypoglycemia, take an extra sample and preserve it, right? Because that's a very important sample, because you are not going to say that, Sahib, morning mouse hai tyare joshu, right? You have to correct the hypoglycemia, right? You can't have a patient with glucose of 30 and say that, I'll first investigate and then you are going to treat the patient. But while you are treating the patient also, it's very important that you take one sample which has to be captured, which is called the critical sample. And the investigation we should be sending should be done from that critical sample. And this is a very important fundamental point, because I've seen a lot of patients, a lot of doctors making this mistake. A lot of times what happens is that I have seen, physicians send morning fasting samples, right? When the patient had hypoglycemia 2 days back, and then you send the sample after 2 days. It doesn't make any difference. What's the point, right? You're not going to get any physiological meaning out of those things, right? The important thing is, when the patient had hypoglycemia, that point of time a sample should be captured, and that should be sent for investigation, right? All this insulin levels and C-peptide levels which you're going to discuss, this should be sent when the patient has hypoglycemia and not otherwise, right? In some cases, yes, but mostly no, right? So if you have a patient with hypoglycemia occurring after the meal, you'll obviously have to trigger that hypoglycemia, right? So to trigger that hypoglycemia, we have two options. Either you do what is known as extended OGTT, which is now outdated, because what people realize is that when you give extended OGTT is basically glucose, right? So you give glucose 75 grams, and then after every 30 minutes you take samples, and when you develop hypoglycemia, you capture that sample, right? But problem is that a lot of normal people also start developing hypoglycemia after extended OGTT, which may not happen in a patient, because we are not taking glucose all the time. We are taking a meal, normal meal. So what they said is, instead of doing that, why doesn't the patient take the normal meal, which he is generally taking, whatever he is regularly taking, take that meal, and then keep capturing glucose values every 30 minutes to 1 hour after that meal, right? So the patient, so it's a very simple test to do. All you have to do is call the patient, bring the food which you are eating at home, which is developing hypoglycemia, right? Sometimes patients have hypoglycemia triggered by specific food items, right? Whatever they are eating and whatever has triggered the hypoglycemia last, ask them to bring that food. Take samples every 1 hourly, right? Till the patient develops hypoglycemia, till you have a sample which is glucose is less than 60. That's your critical sample, right? That's the sample you should capture in these patients, right? That's the critical point. And in this sample, what are the tests you have to do? So A, always send a glucose in the lab, right? I'm sure you would have done this by glucometer, right? So you need to cross check with the lab. So you send a lab glucose. You need to send a C peptide. You need to send the insulin, and I would also suggest cortisol, right? These are the samples you should generally consider. Cortisol is less important for postprandial hypoglycemia, more for fasting hypoglycemia, but at the same time it's a good idea to check that also. We'll discuss the importance of each of these as we go along. But in this patient, the important point is that you need to capture the critical sample. So if the patient has a fasting hypoglycemia, patient comes in the emergency with hypoglycemia, just एक sample, take an extra sample, right? Or maybe 1 or 2 extra sample, you keep it preserved. And then you can think about what to do in the morning, and correct the hypoglycemia, right? But critical sample should be captured. If you have a patient with postprandial hypoglycemia, which is more difficult, you have to induce that hypoglycemia in a controlled environment and take that sample, right? Now, so it's very important that you capture the critical sample. Sometimes what happens is, patient comes in the emergency. Now, this can lead to a problem, right? Patient came in the emergency, non-diabetic hypoglycemia, everybody is panicking, or they check the sugar at home, it is already low at home. They already start correcting it, right? They already start giving glucose, sugar, everything. By the time the patient comes to you, sugar is normal. So you have lost the opportunity to take the critical sample. Now, what do you do in that case? So in that case, you have to do a very painful procedure called 72-hour fast test, where you have to admit the patient, right? Keep him or her in fasting. It says 72 hours. Trust me, if the patient truly has hypoglycemia, within 6 to 12 hours, patient will develop hypoglycemia. If the patient doesn't have truly a hypoglycemia, we have done a lot of 72-hour fast tests, and basically, got tired at some point and said, okay, now let's let it go, right? Or capture the sample within few hours, right? So truly, patient with a insulinoma will develop hypoglycemia within 5-6 hours. But patient is just having anxiety, probably not having anything, right? I'll tell you what we do these days, for such patients when we have this. But the idea is that technically in textbook and maybe open Harrison, this is what they'll say, you do 72-hour fast test, but ideally it is not for, don't worry about never have to go for 72 hours. Either you will give up before 72 hours or they'll give up before 72 hours, or they will have hypoglycemia before that. That is the thing, right? So technically you do that. For postprandial hypoglycemia, you have to do mixed meal stimulation test, right? Now, we discussed postprandial hypoglycemia, and this first case was postprandial hypoglycemia. So what do you do? I'll also tell you what do I do practically in a lot of these patients. So what are the conditions? So a very important and common condition is called postprandial syndrome, which is what this patient had. But it's a diagnosis of exclusion. So you have to rule out other causes, right? So when you have a patient with postprandial hypoglycemia, you can't say you need to rule out other causes. Another important cause we have now 3 patients with what is known as NIPHS, which is non-insulinoma pancreatococcus hypoglycemia syndrome, which was previously called nesidioblastosis, adult onset nesidioblastosis, where so difference between a nesidioblastosis and insulinoma is that insulinoma you have one tumor, whereas nesidioblastosis all the beta cells are hyperplastic, right? So that is what you have. That happens in certain patients. Insulin autoimmune syndrome, right? We'll discuss this a little bit. Post gastric bypass. These patients who have gone, gastric bypass surgery, sometimes even for cancer, they have this very typical postprandial hypoglycemia syndrome. I've seen a lot of patients. Post-bariatric surgery, very common. We have seen so many patients, right? They develop postprandial hypoglycemia, very, very common. Insulinoma can lead to both fasting and postprandial hypoglycemia, but it is then sometimes present with only isolated postprandial hypoglycemia. Less common, but it is something you should consider. Hereditary fructose intolerance. Some people have hereditary fructose. This is diagnosed in childhood only, most of the time, because it's captured early. Factitious hypoglycemia. Sometimes they take insulin or sometimes sulfonylurea. They take all that, right? Mild early type 2 diabetes, post pancreatic transplant, right? And large amount of alcohol with gin and tonic syndrome, it's known as that, right? So some people develop hypoglycemia after. So these are all causes of postprandial hypoglycemia. Now the most common is this condition, which is called postprandial syndrome. It was previously known as reactive hypoglycemia, which is now re-termed as postprandial syndrome. It's very, very common. It is so common that you will almost remember some patient of yours you would have seen in this kind of way. Everybody would have seen this patient, but now we are giving a name to it. What happens is this is typically what happens in Indian patient is very common. It happens in very early diabetic or somebody who is pre-diabetic, just develop. It's very, even my father had it, I remember, right? Thankfully never developed diabetes, but he had that pre-diabetic, I still remember that. You would have also seen sometimes lab reports where the fasting sugar is 110, post-meal sugar is 60, right? These are all reactive hypoglycemias. Now what happens in this condition is, especially Indian patients, in early Indian patients with diabetes, remember the first phase insulin secretion we have, right? We all have first phase insulin secretion, which should be robust, right? But in diabetics, that first phase insulin secretion, or early pre-diabetics, this first phase insulin secretion becomes slower, it becomes late, right? So the glucose comes and then it gives a signal because of the incretin pathway to release insulin, but that release of insulin occurs late, right? So sugar comes, glucose comes, gives a peak, goes away, and then the insulin gets released late, and when the insulin is being released, that time the glucose is going less, and that time you have this mismatch and they develop hypoglycemia. This is reactive hypoglycemia. It's very common, and so this is the problem, right? This is the problem which you'll see. Eventually what happens after a few years, there, over a period of time, that insulin production becomes less and less. So you don't see this in diabetic patients, that first phase insulin secretion which was delayed, now first phase insulin secretion becomes decreased, right? The amount of insulin itself goes down. Because amount of insulin goes down, they don't have hypoglycemia, but rather they persistently have hyperglycemia, right? So when you see this reactive hypoglycemia patients, and if you are doing a mixed meal stimulation, you'll typically see that 1 hour or 30-minute sugar, there'll be a peak. Sometimes sugars may also go to 200, right? But then afterwards, it starts dropping, and sometimes they develop hypoglycemia, right? So this is how this develops, right? Now, it's, like I said, very common. Such patients, if this patient came to me, I would not do a mixed meal stimulation in today's world. What I do is, when I know for sure, right, of course you rule out other conditions, but when I know for sure that this is most likely to be mixed meal, postprandial hypoglycemia or postprandial syndrome, I just put a CGM. Put a CGM and tell them, or put a blind CGM, don't put Libre, put Libre Pro, right, where the patient is not able to check the sugar, right? Just put the CGM and tell them that when you have the symptoms, just note that sugar down, note the time down, right? And then cross-check with the CGM, and you'll find, and you'll find the classical pattern. You show it to the patient also that, look, this is what is happening, right? And then you make the diagnosis. So instead of doing in today's world, of course, this is not published, established anywhere, so this is off-label. But ideally, again, textbook answer should be do mixed meal stimulation. But in a practical sense, this is what I do. We have a lot of patients like this, and this condition is probably the most easiest to treat also. So we have seen, like I said, a lot of similar presentation, but of course you have to be careful, rule out other conditions. Post-bariatric, exactly the same problem. NIPHS, these are patients, where you will see this. Insulin autoimmune syndrome also you'll see similar present. It's this, this condition, it's very easy to treat, All you have to give is acarbose, right? Now the magic, what happens with acarbose is, acarbose can't make the insulin release early. It can delay the glucose absorption. So what it does is it delays the glucose absorption. The glucose, that peak which comes and which stimulates insulin, does not happen. So the insulin peak is blunted, right? And the glucose absorption is slowed down, and you have magical results. Patient, literally the symptoms go away, right? Sometimes, however, we always give, sometimes we give 25 mg TDS, 50 mg TDS. It is sometimes not enough. Right? Actually, if you see pharmacology textbooks also, the standard dose is 50 TDS or 100 TDS. Right? You might sometimes, a lot of patients have to go for 100 mg also, right? And depending on the patient, depending on the meals they are having. Another very important counterintuitive problem which patients do is that patients start, because they feel that they are developing hypoglycemia, they start having a lot of sweets, which is exactly what you should not be doing. Why? Because the problem is insulin release. So when you take more short-acting carbohydrates, there is more robust insulin release, and because you have more robust insulin release, there will have more hypoglycemia, right? So if they take more glucose or they take more sucrose, more sweets, instead of preventing hypoglycemia, it actually triggers more hypoglycemia, and this is the loop they fall into, and then they come to you, right? If they just figured this out, कि sugar बंद कर दो ना, this goes away, they will not come to you because they'll solve the problem on their own, right? But so very important meal advice you give them, that take small meals and don't take sugar in the meal. right? And when they do that, and sometimes what happens is that they develop hypoglycemia, they take sugar that time, and then develop another hypoglycemia. So it keeps triggering, right? So that's the problem, right? Similar thing you see in a lot of other conditions also. Post-bariatric, it is very common. I have seen a lot of patients. Insulin autoimmune syndrome also, unfortunately, this is again not very visible. Is there, okay, no problem. Probably should have a black background. So insulin autoimmune syndrome is something which is again not that common. It is known as Hirata syndrome. You will see rarely, but you will have typical hypoglycemia patients coming with. In this condition, what happens is that sometimes you have antibodies against insulin, right? So certain antibodies which form against insulin, these antibodies bind with the insulin, right? So the insulin is released and that antibody binds with the insulin, and after some time it dissociates the insulin. So insulin gets combined into a reserve, into the antibody, and then after a few hours it just dissociates. Suddenly you have a big release of insulin in the body, suddenly patient develops severe hypoglycemia. Now Hirata syndrome was first described with carbimazole and methimazole in Japanese patients. It is very common in Japanese. In fact, the most common prevalence is there. So it's very well known to occur with non-diabetic patients taking methimazole and carbimazole. So especially when you have such patients, be careful. I've seen Hirata patients with carbimazole, right? Methimazole in fact is even more common from the reported literature. That is one. Another very common drug, another two most common drugs which lead to that. So this is a big list of drugs which lead to all these things, right? Couple of common other drugs which can lead to this. One is clopidogrel. We had one patient who had clopidogrel induced, this type of thing. We stopped the clopidogrel, hypoglycemia within few weeks went away. Right? Triggering drug went away. Another very common drug which is now so well known that it is in, if you see their product literature in Europe, it actually gives a warning of Hirata syndrome. It is ALA, alpha lipoic acid. Alpha lipoic acid is part of all these mixtures of multivitamins where ALA is very commonly known to trigger. And another common drug where we had seen couple of episodes in my career I have seen is pantoprazole. These are some common drugs which can lead to very, you'll only see isolated cases one or the other. ALA is so common that it is now part of, but and it's an autoimmune disease, so you can not necessarily, you do not know, predict who will develop. But most of the time, if you can identify the offending drug, right, you just stop the drug, monitor, and after a few weeks it goes away, right? That antibody disappears, triggering very commonly, like I said, with methimazole, carbimazole, but these are other things which can also lead to similar presentation, right? Okay, let's look at the second case now. So you have a 25-year-old lady. This is a very, very nice case. It's so rewarding, right? It's a very rewarding, good ending to the story. However, all the three stories are good endings, thankfully, but this one especially. So you have a 25-year-old lady. I get a call from physician in Bhuj. The girl is having recurrent hypoglycemia, had recurrent seizures also. Recent history of severe headache. Patient is transferred to us with dextrose infusion from Bhuj. Infusion sathe, the patient is sent. Right now, so when the patient comes, we take this history. Patient has mainly, we always take a complete history in that sense. And the patient has main problem had infertility. For a long time they're struggling with that. She had oligoamenorrhea. In fact, last few months she had just amenorrhea. And weight loss. These were the history, right? So this was the presenting, and again along with that the patient started developing hypoglycemia. So when we saw the patient, the RBS was 77. Thankfully, patient was already on dextrose and all that. We send the cortisol, random, right? Patient had just come, send the random cortisol. We send the thyroid function, ACTH. Now you can see the reports, right? So cortisol is 2.4, right? Free T4 is low, okay? TSH is normal, quote unquote normal. ACTH is 1.2, which is again low. How do you interpret this result? Right? So still technically not hypoglycemia, but she was on dextrose, right? But look at the cortisol, free T4, TSH, ACTH. So cortisol is low, T4 is low, ACTH is low. Right? Right. Correct. So you're dealing with a pituitary disorder, right? Always remember, I said, yeah. So when you have a pituitary, this is central hypothyroidism, adrenal insufficiency, pan-hypopituitarism, technically. And we will take the patient's history, patient has infertility, patient has oligoamenorrhea, right? So immediately, right, the focus went on pituitary. So we did an MRI. And you see this is empty cella, right? So you see this all here, this is all, this is used to be pituitary in the past, right? This is empty cella. One very rewarding cause of hypoglycemia is adrenal insufficiency, right? This is, sometimes you often forget this, right? Hypoglycemia is a often a clinical presenting feature of adrenal insufficiency. Another very important, and I think we have discussed this in past also, hyponatremia. So hyponatremia and hypoglycemia, always think of pituitary, right? Because I'll tell you one more thing, adrenal insufficiency is way more common than we think, because a lot of patients have been on and off on steroid, COPD patients, asthma patients, rheumatological condition and so on, COVID patients, everything, right? A lot of patients take alternative medications also, a lot of times which may also contain glucocorticoids, right? So there are challenges, right? So adrenal insufficiency is very common. So in this case, we diagnose this patient as pan-hypopit. Hypoglycemia and adrenal insufficiency, I'll tell you some very important clinical pearls here. Primary adrenal insufficiency, metastasis, tuberculosis, histoplasmosis, autoimmune, right? Autoimmune is Addison's, right? Very common. You see a patient with tuberculosis having darkening of skin, hypoglycemia, weight loss. Think of adrenal. We have done so many patients. We did CT scan. You find adrenal, you find calcification in adrenal, right? A lot of these patients have adrenal insufficiency, right? Always look at, your TB patients, you should always look for. HIV patients, look for it. Histoplasmosis is common there. Exogenous Cushing syndrome, right? Patient looks Cushingoid. Patient is taking steroid for a long time, right? And somebody stops the steroid. Patient gets admitted for some other reason. Steroid is stopped. Hypoglycemia, right? Post pituitary surgery, obviously, somebody has done a pituitary surgery and then forgot to replace the, again, Sheehan syndrome, right? Sheehan syndrome is postprandial syndrome, right? Postpartum syndrome. A lot of patients have, and we have seen 57-8 patients, this condition called autohypophysectomy. Sometimes patients have a large pituitary tumor. It becomes so large that it outgrows its blood supply. It's not diagnosed, right? Outgrows its blood supply. The blood supply kind of, patient develops apoplexy, right? That is also not, sometimes not diagnosed. Ideally it should be, right? And then gradually the pituitary shrinks. And when the patient comes to you, they comes with pan-hypopituitarism. There's so many patients like that, right? Patient looks typically acromegaloid. See, this is acromegaly, but you see the MRI, it's, you have large enlarged cella, but empty cella, right? So that is known as autohypophysitis. Similarly, you have granulomatous hypophysitis or lymphocytic hypophysitis with similar presentation. Viper snake bite, important cause of pituitary apoplexy. It's very well documented in literature. And you have a viper snake bite going into shock, hypotension, not coming out, think of adrenal insufficiency, pituitary, at pituitary level, right? And post radiotherapy. Radiotherapy also, it damages the pituitary, especially when you have non-targeted thing, right? Management, obviously, you replace the deficient hormone. So this patient had multiple hormone being replaced. When you're replacing hormones, remember, patient, whenever you're giving thyroid and adrenal, glucocorticoids, you have to give glucocorticoids before you give thyroid, right? So always start glucocorticoids and after 2-3 days start thyroid, because sometimes when you start this patient on levothyroxine, the metabolic rate increases and the cortisol, whatever is there, that also starts dipping down. Patient develops adrenergic crisis, right? So that is something you need to be aware about. So important take-home message is adrenal insufficiency, a very important cause of hypoglycemia. Now we treated this patient, sent the patient home after replace the hormones. They went for IVF. They went somewhere else. They were transferred somewhere else in Haryana. They're in constant touch. And this is the message again. Yeah. So they just few months back, they in March they delivered with IVF, which is from a patient with a near-death experience, right? Literally having seizures and all to having children, right? It's the entire, so that the fertility thing also got diagnosed because of that, right? Because then you knew what the problem was, right? So that is the thing. And third case, this patient came with luck written on her sleeves because it couldn't have happened. So this is again 25-year-old pregnant lady. Now this is that morning, I remember it was frantic for us. She has seizures in the last trimester close to term. Glucose that time was 26. Okay, seizures, pregnant woman. Right? Think what would have happened to the treating people, right? Started on glucose, anti-epileptics. She was close to term, so they did her. Hypoglycemia seizures, they did LSES. Hypoglycemia postpartum persisted, right? They had no idea. They put her in the ICU, started giving dextrose, everything. Next day morning, they said, okay, we'll send it to Zydus, right? The patient came in the morning, physician called me, okay, how you manage this, right? We don't know what it is. Luckily, we could capture the critical sample that is. As soon as the patient came, the glucose was 30, I said, you take the sample, right? Critical sample was then, we started dextrose infusion. patient was already on dextrose infusion. There was a patient, the glucose requirement was very high. We started oral. I'll show you the treatment which we were given. We started everything. We said give everything, right? We don't want a postpartum lady to die, right? Diazoxide, octreotide. She was already given anti-epileptics. We put SOS glucagon also. Glucagon bhi mangai rakho. Maybe the patient would need it. Some of these patients, especially we didn't have the reports, but by hunch we thought that it's insulin-dependent hypoglycemia. We did the, of course, cortisol and everything. Patient did not have, the cortisol was 26 or 27. It was pretty good. So octreotide we gave 100 8 hourly. This is sometimes you give for resistant hypoglycemias, especially insulin-dependent hypoglycemia. Diazoxide is now available in India. So we started the patient which is known as Balila and 10% dextrose. We started 80, then we had to increase to a lot of time. It's always good idea to give, instead of giving boluses of dextrose, give infusion, right? Always remember that. It's always better. And of course, thiamine and all that, otherwise you'll have a bunny case and those things, right? So glucose was 36. Now you see the reports, right? This is where we'll discuss the importance of the investigations. C-peptide was 6. Insulin was 68, beta hydroxybutyrate, which is ketone, is 1.2, and cortisol, which is lowish, and cortisol was 21. So cortisol excess more than 20 means more or less normal, right? When the patient has hypoglycemia and the cortisol shoots up to more than 18, 20, it is fine. So that problem is not there, right? Because again, that should have been the first suspicion as well. So what is the interpretation of this result? Now this is what we'll discuss, right? Again, unfortunately, we can't see this, but when you have hypoglycemia, such kind of patients, you have captured the critical sample, it's important to differentiate insulin-dependent hypoglycemia from insulin-independent hypoglycemia. This is the main differentiating parameter, right? So, typically, when you have a critical sample, the glucose less than 55, if the C-peptide is more than 0.6, so ideally, in the first line of defense against hypoglycemia in human body is to reduce insulin secretion. That is the first line. Then glucagon starts, then epinephrine, norepinephrine starts, right? So it goes in that cycle. So first is that if the patient has hypoglycemia, the patient's insulin level should come down, right? If you can still detect insulin in the body or C-peptide in the body when the patient has hypoglycemia, that means it is something wrong with insulin secretion. It is insulin-dependent hypoglycemia. So we do insulin level. Sometimes if you have pro-insulin available, you can do pro-insulin level. And remember, when you have insulin being released, now if the patient has hypoglycemia and there is insulin being released, insulin will suppress ketone production. So patient will have low levels of ketones. Whereas if you have starvation, you would have seen a lot of patients who are, Jain monks and all that, who starve for a long time, they start developing hypoglycemia. Patients with, some sort of malnutrition disorder, these patients will have very high ketones, right? Because the problem in that case is starvation. It is not, they are not having nutrition, right? So that hypoglycemia is different from this. Here, problem is not starvation. Problem is insulin, right? And hence their ketones will be low. So this is something we should do. So our interpretation was that patient clearly has insulin-dependent hypoglycemia. Now, the number one cause of insulin-dependent hypoglycemia is insulinoma, right? So that is what we. Now, I had never seen in my career, and I've seen a lot of insulinomas, but I've never seen a postpartum patient with insulinoma. I'd never seen, right? So I still don't know, what really happened, because it's still that thing is days. So we directly sent. I said this is insulin-dependent hypoglycemia. Patient was in the ICU. Patient was stabilized. He said we send her to CT. We sent the patient for CT. We did the pancreatic protocol. Biggest problem with insulinoma is that these little buggers are very difficult to detect, right? CT scan was normal, right? So what do? Right? Now you are in fix, right? So you are admitted this patient, insulin-dependent hypoglycemia. What do you do next? So we were very sure that the level of glucose required, this patient probably has insulinoma, right? There is something there. So what do you do for imaging? Now this is the very interesting part about imaging, right? So first of all, USG has no role. USG will never pick up. It is unlikely to pick up an insulinoma unless the patient has metastasis everywhere, and that also it's. But non-contrast, low resolution CT scan, again it will not pick up, right? Because they are sometimes very small. Right, you require a dedicated CT pancreatic protocol, but even in that, 30% cases will be missed. So, in a modern world, you have these three options, right? Always do stepwise, always do CT scan first, because you might pick it up on a CT scan. But if you don't pick it up on a CT scan, you are strongly suspecting insulinoma. These three are your heroes. Endosonome, right? Often picks up. We had patients where we have picked up on endosonome, right? So you talk to your gastro, send for endosonome. Gallium DOTA PET is an option. which we have used a lot in the past, but now we have the best available marker for this, which is DOTA exendin scan, right? Exendin is a very specific, tracer for insulinoma, right? And this patient's luck was that I called up my, the nuclear medicine Sunny Gandhi. I called him. He said, "Taru je ek patient hai, jema we had asked for exendin scan. That same patient has come, so we have the tracer today. So there's some other patient where we were looking for insulinoma, right? Who was stabilized on outpatient basis. That patient had come that day, and that tracer was available. He said, I have extra tracer. So you immediately stop everything, send the patient, right? So you send the same patient, right? Otherwise, it takes 2 weeks to order the tracer and all that, right? So we would have gone for DOTA PET, which probably would also not have picked up the lesion, right? Maybe, right? So the best, if you have one thing you have to do exendin, right? If it's available, but availability is still a problem. So we did the PET exendin, and you can see the lesion, right? This is the lesion. We picked up the lesion here, right? And immediately called the surgeon. He did a robotic spleen preserving distal pancreatectomy, right? Immediately, so this is the histopath. Again, you're not able to see. It's a low grade. It turned out to be a low grade tumor, right? Within days, right? Within day 1 stabilized CT scan, day 2 exendin, day 3 surgery, right? All in sequence. Again, because you can't see postpartum, right? We stopped everything, right? No hypoglycemia. It just went away. This is November, just recently. We asked them to keep checking the sugar at home. They kept checking sugar and sending. You can see the last sugars, they are all absolutely normal, right? Perfectly normal sugar. He said, bye, it's over, right? That thing is over. Low grade, right? Complete luck, right? This is complete luck. The patient came, otherwise the patient would not have survived, because the hypoglycemia was so severe that, it would have been literally impossible, without, and that, that brief period when the patient was transferred from the, that dextrose was stopped for almost 10-15 minutes, patient's glucose went to 30, right, in just that time, right? She was on anti-epileptics, but I mean, you don't know, I mean, that one bad seizure and, you could have permanent hypoglycemic brain damage, right? So, just to summarize, 3 important points, right? Whipple's Triad should always be established, because for every such patients, you will see a lot of patients who don't have anything, right? So always have, this eyes and ears open where you say that Whipple's Triad should be fulfilled to label a patient having non-diabetic hypoglycemia. Second, always try to capture the critical sample. This is a must, right? You must be doing this. Third, hypoglycemia with suspected insulinoma, conventional imaging may miss. So it's always a good idea to consider 3 important, right? So I do endosono or PET, and you will be able to pick up a lot more lesions with much more ease and much more rewarding.